Epilepsy is one of the commonest neurological conditions in children. Um, when we talk about epilepsy, we talk about seizures. And if you look at a school, an average size school, which consists of between 4,000 to 5,000 children, you would have at least 40 to 50 children with a diagnosis of epilepsy. Now, many a times this has not come to the attention of other pupils or the teachers. That's because it doesn't happen all the time. But having a first seizure in a child is one of the most frightening events in any parent's life, and that's something that they never forget.
Epilepsy is the fourth most common neurological disorder and affects people of all ages. Epilepsy means the same thing as seizure disorders.
When the child has a first seizure, the first thing that strikes parents is a sense of fear, a sense of helplessness. The time flies off, and it's very difficult for them to recollect what happened to their child. When you go to a doctor, the first thing he or she asks you is, just narrate to me what exactly you saw, what happened before, during, and after a seizure or a fit. And it's quite difficult to do that. And sometimes we ask parents who've seen more than one seizure to make sure that they video the event. So the exact semiology or the exact sequence of events are shown to the doctor at the time of consultation. Now, usually epilepsy can be diagnosed quite easily by a pediatrician or a pediatric neurologist, but many a times it can be difficult. And that's because there are many events that mimic epilepsy or that look like epilepsy to an untrained eye. The common ones are breath holding spells in toddlers or very young ones, where they cry, and at the end of the cry they hold their breath, they become blue and become limp. And this is called breath holding spell. It's quite common in young age. Fortunately, they grow out of it. The other one that can mimic epilepsy is something called as febrile seizures or febrile convulsions. And this is where a child has a fit or a seizure secondary to high temperature. Again, fortunately, children grow out of it by the time they're 6 or 7 years of age, and no long-term anti-epileptic treatment is required. But what parents need is appropriate advice with regards to what to do when the child has his or her first febrile seizure and subsequently.
Epilepsy can have both genetic and acquired causes, with interaction of these factors in many cases.
Epilepsy, by definition, is an individual having two unprovoked epileptic seizure. What I mean by unprovoked is that the epileptic seizure should not be secondary to a high temperature or an infection or a low sugar in the body. It has to be unprovoked, and on 2 occasions. The science behind epilepsy, we all know that epilepsy comes from the brain, and all of us have a certain pattern of electrical activity in our brain. In some children, either because of an injury that they sustained in the past, or because of their genetic propensity, they have abnormal electrical discharges coming from different parts of the brain. Now, depending upon which part of the brain is involved, the symptoms in a child is seen. For example, if the epileptic activity comes from all over the brain, it leads to what we call a generalized seizure, the whole body shaking. If it comes from a specific part of the brain, like say the temporal lobe, as we call it, which is on the side of the brain, it can lead to only blanking out, and sometimes the seizures or the fit happen on only one arm or one leg. So it depends on which area of the brain is involved. That will be reflected in what type of seizure the child has. People ask me sometimes, what happens to my child during a seizure? That's quite a difficult question, because when a child has the most common type of seizure, which is generalized tonic-clonic seizures, they're usually unconscious, and there is this chaotic activity or electrical activity going on in their brain. And when they come out of it, they're quite drowsy and sleepy, and when they're awake, they don't remember what happened to them. But occasionally, children have what is called as focal seizures, or seizures coming from a certain part of their brain. And in these kind of seizures, the children maintain the awareness. Sometimes they have what is called as an aura, that they know that the seizure is coming. They have a kind of sensation, which can be a sensation of feeling, or hearing noises, or seeing some things that are not there in front of their eyes. And these are called aura. And following this, they can have a seizure. And sometimes when you talk to them, they can listen to you, and at times cannot respond. So these type of focal seizures can present in a different way.
The diagnosis of epilepsy is typically made based on observation of the seizure onset and the underlying causes.
The diagnosis of epilepsy is usually clinical. So basically, you don't need to have any tests to make a diagnosis of epilepsy. It's based on the history that parents give us and a video footage if the parents bring it to us. Just by looking at what happened to the child, the diagnosis can be made. But at times, various tests are arranged to identify the cause of why your child has a seizure, and also to understand what type of epilepsy it is even better. So the most common test that is used is called as EEG or electroencephalogram. What happens during that is your child is brought in, and there's some electrodes or some sticky tapes that are put onto the head of the child, and the electrical activity of the brain is studied. It takes 30 minutes, at times 40 minutes to do the tests. Sometimes the younger children are put to sleep because they can't stay still. And again, the test lasts for 30 or 40 minutes, and we can study that very clearly. Here at our center, we do a number of such EEG variants. Like you can have a standard EEG where it is done just for a period of 30 minutes. There's something called as ambulatory EEG or prolonged EEG, which goes on for 24 hours. It is attached to a child, the child is taken home and then brought back the next day with the unit, and the whole 24-hour period brain activity is studied. Sometimes what we do what is called as video telemetry. That is, the child is admitted to a hospital, and the event, if it's happening on a regular basis or a daily basis, is studied. So EEG is one of the crucial tests for understanding the type of epilepsy a child has. Sometimes MRI scans are arranged. Now, MRI scan is understanding the brain structure. And in younger children, the child has to be put to sleep. But in older children who are 7, 8, 9 or above kind of age group, they can have the MRI without any sedation. And what it tells us, it gives us a structure of the brain and identifies any abnormality or malformation that might be present in the brain. Apart from this, some blood tests are arranged to rule out the common metabolic disorders or disorders of various salts in the blood. And this is a panel of blood tests that we do. And I think in terms of investigations, that is, these are the three group of tests that we do to understand the kind of epilepsy a child has. The treatment of epilepsy has evolved over almost a couple of centuries, in fact. In the past, people used to use witchcraft and things like they used to say that the child has been possessed. They used to lock the child up completely, and at times individuals were put to death because they had epilepsy. Because of these misconceptions and misunderstandings, epilepsy was not studied that well. But over the last century or so, the treatment of epilepsy has evolved. For example, in the 1930s and 1940s, we had two common medications we used called phenytoin and phenobarbital. But as time went on, in the last 25 years or 30 years, now we have close to 30 or 35 different anti-epileptic medications that can be used. And the newer anti-epileptic medications have lesser side effects and, if not better, at least equal efficiency to control the seizures. But the medications have to be used in the right hands with the right doctor who has the competency to understand the kind of epilepsy a child has and appropriate medication used.
Sometimes EEG testing, clinical history, family history and outlook are similar among a group of people with epilepsy. In these situations, their condition can be defined as a specific epilepsy syndrome.
The alternative therapy is something called as vagal nerve stimulator or VNS. It is a small device that is inserted on inside the skin, just below the left shoulder, and the wire is connected up to the vagal nerve. And it sends impulses on a regular basis and controls the seizures. Yes, it is a surgical procedure, but more and more children are enrolled onto it now. And the third group of therapies are called surgery or epilepsy surgery. And for this, you need to have the resources and a thorough evaluation of a child before a brain surgery is carried out in a child. And there are centers all around the world who specialize in this.
If the neurologist determines that a person has epilepsy, he or she will recommend an appropriate type of treatment. Treatment for epilepsy usually involves medication, but sometimes other treatments may be recommended.
You will hear names like sodium valproate, carbamazepine, lamotrigine, and these are the names of the medication themselves, or pharmacological names. But the common brand names, for example, in the UAE are medications like Depakin, Lamictal, Keppra, and these are used in children and have been used for many decades. We normally start a child on one medication to control the seizure and build up the dose very slowly. And in majority of them, that is close to 50% of them, we're able to control the seizures completely. If the first medication doesn't help, we introduce a second one, and then about 60 to 65% of children with one or two medications, their seizures can be stopped or controlled. But there is always this group of 1/3 of children with epilepsy, and no matter what medications are used, they will keep having seizures, and they come under this umbrella of refractory epilepsy. And for this, all around the world, a lot of resources, a lot of thought process has been put in to research what to do with this 1/3 of children who are refractory to medications. And the alternative therapies have started. We use something called as ketogenic diet, which is a high-fat, low-carbohydrate diet that is introduced to the child, and it has very good benefit in controlling the seizures. And actually, ketogenic diet has been used more than 90 or 100 years ago, but it fell out of fashion over many years because new medications were coming up. But in the last 20 years or so, it has resurfaced as one of the commonly used alternative medication.
The neurologist will most likely perform medical tests such as an electroencephalogram or EEG test to measure the electrical activity in the person's brain.
There are a number of myths that go with epilepsy, and this has been the case with epilepsy for a number of years. In my practice, in our center, I have parents coming to me and asking me specific questions that they have either read or have been told about. And they tell me that they ask me whether epilepsy is contagious. And the answer is no. Epilepsy cannot be passed from one person to another, or by touch, or by any other way of communication. If it happens in a child or an individual, it is with that child or an individual. They ask me whether only if children suffer from epilepsy. Again, that's not the case, because yes, lots of the epilepsy normally starts in childhood, many a times, but adults also suffer from epilepsy, either because they had epilepsy during childhood and they've carried it through, or the epilepsy has started later on in adulthood. The common question that I get asked from parents is that, is my child going to be disabled, or are they going to suffer from disability? And the answer is, most of the children with epilepsy are not disabled. They have they have the ability on par with any other child going to a school or older children going to a college. Usually, children who have well-controlled epilepsy have a normal level of intelligence, and they have normal level of physical ability. Some say a child with epilepsy should not be in a role of responsibility, or an adult with epilepsy should not be in a role of responsibility, and that is not true either. What they should not be doing is to be in a job which can risk themselves or other people around them. But most of the jobs that any other person can do, a child or an adult with epilepsy can carry out.
Seizures may look frightening, but they're not painful. They affect different people in different ways.
There are different types of seizures that are witnessed in children. The most common of these is the generalized tonic-clonic seizures, as we call them. This is what we see in movies and on YouTube channels, where the child either cries out or just falls onto the ground, and after falling onto the ground, they stiffen up, the whole body stiffens up and they arch back. This is followed by clonic movements, or shaking of all the body, and sometimes just one side of the body. And this can go on for 2 minutes, maybe 3 minutes, sometimes longer in some children. During the episode, the child can be incontinent, that is, wet themselves. They can bite their tongue, And when the seizure stops, they become drowsy and sleepy. So this is the usual pattern that you see with the most common type of epileptic seizure. Beyond the generalized tonic-clonic seizure, there are other forms that can happen in a child. It can be only tonic, that is the child only stiffens up. It can be only clonic, that is the movements are ongoing but they are only shaking. There are some types of seizures called absence seizures, or previously called petit mal, which is a French name given to it. They were called petit mal because they were thought to be minor seizures or small seizures, but now we don't use that term anymore. Child basically just stops and stares for a few seconds, maybe 5 or 10 seconds, and they can have 20 to 100 such episodes in a day. And absence seizures are sometimes misdiagnosed because lots of children have daydreaming and preoccupation episodes, and that itself can lead to wrong diagnosis of absence seizures. So these children have to be evaluated very thoroughly and systematically. The other form of seizures is called the myoclonic seizures, where a child has intermittent jerks, either whole body jerks or arms, and that also has a specific underlying diagnosis that needs to be made.
Epilepsy surgery may be an option for people with partial seizures that remain a problem despite other treatments.
What's crucial is to have a very specific and correct diagnosis in your child, because that will be the basis on which the outcome of the child's treatment will depend. When you start a child on treatment, we normally start at a small dose and build it up very slowly. I've had cases or parents who come to me and said they have stopped the medication, and that is absolutely a no-no, because that can cause more harm to the child than good. You should not stop the medication abruptly. You have to discuss it with your doctor or your medic before it can be slowly withdrawn. Some parents have come to me and started them on medication on their own, and that again is even more harmful. So any change of medication or introduction of anti-epileptic medication has to be done by a trained neurologist or a trained pediatrician who knows what he or she is doing. There are many side effects of individual medication, like the most common one that we use called Depakine or sodium valproate. The child can put on weight. They can be slightly more sedated than usual. It can affect their behavior. The liver functions can be affected, and appropriate monitoring has to be put into place. So regular attendances at outpatient department is essential. Again, many parents opt to go ahead with alternative therapies like herbal medications or things like giving them hot baths and so many other things. I personally don't put them off from this, but I don't kind of recommend this because there are no tests or research that has been carried out to prove these alternative therapies. But you should not do anything that harms the child. And if that were to be the case, then I normally tell them or put them away from it if needed.
Often someone's epilepsy is accepted as part of who they are, so taking on any additional care because of their epilepsy can be seen as just the way it is.
The news of the diagnosis of epilepsy in a child comes as a shock to parents. And I've seen lots of families being disrupted, parents losing their job, parents having problems with their spouse, with each other, and the relationship between them and the children being destroyed with the diagnosis of epilepsy. But that should not be the case, because reassurance is paramount when a doctor makes a diagnosis of epilepsy. I tell parents that if your child has been diagnosed with epilepsy, there is an extremely good chance that we'll be able to control the seizures that he or she has. I give them a complete package of information as to what to do if their child has a seizure, which we discussed earlier, is to stay calm, although it's easy to say, and make sure that help is at hand, to call the ambulance, and to make sure the child is safe. And I also reassure them by saying the seizure usually will stop on its own, and in children who have prolonged seizures, I give them something to keep at home that they can administer to the child to stop the seizure. So seizures or epilepsy can be controlled, and most of the children can be made seizure-free with the right medication and with the right medical treatment.